So now it is our sheer pleasure to invite one of our very old friends, Dr. Nitin Burkule, who frankly speaking doesn't need any introduction to any audience in cardiology or for that matter to any physician circle in India. And thankfully for us, he has taken up his interest in cardiac cardiac MR in recent times. And a lot of cardiologists from all parts of the country are benefiting from his courses. And it will be a real privilege to listen to him on the role of CMR in the evaluation of cardiomyopathies. And as always, I think he's going to add very new angles and new insights into the subject. So over to Dr. Nitin Burkule.
Thank you, Dr. Soumitra Kumar. It is always a pleasure to attend EZECHO. They are all very kind to call me every year, and I'm very happy to visit the EZECHO because the audience is always very passionate. And let me tell you that actually we got inspired by Dr. Sanjeeva Vishwamitra because myself and my colleague radiologist attended his course at Satya Sai, and we were very inspired and we developed our department in the same way. So thanks, Sanjay. So what I thought that since all of you are clinicians, I will go by cases and show the power of MRI in cardiomyopathy rather than giving a theory. So what we'll do is we'll start taking some very regular kind of cases. So this is a 53-year-old gentleman, known case of aortic stenosis. Serial echoes are showing increasing aortic wall gradient, but it has not gone into the severity range. He has now recently developed LBBB, so his EF has dropped, and his angio is normal, and he is also symptomatic. Now, what extra information an MRI is going to give me here, because he has developed LBBB, LV dysfunction, he is now in a low flow, low gradient severe aortic stenosis category. Now this is his ECG, and you can see there is a LBBB, QRS duration is definitely more than 120 milliseconds, and the echo, as you see, has a very dirty calcified valve, which even in short axis very difficult to make out with this tricuspid, bicuspid and planimeter, that valve. If you look at the gradients are somewhere around 52 by 35. And if you look at the stroke volume, it is hardly, I think it is 37 ml. So if you index to body surface area, it will be around 25 ml per meter square, which is definitely a low flow, low gradient severe aortic stenosis. So let us see what an MRI can tell me more about this patient. Now these are his long axis images, very similar to our echo, except this coronal plane, which we don't get on the echo. We get this 3-chamber, we get this 4-chamber, we get this 2-chamber. Second most important thing is that because of a very clarity of endocardium and epicardium, I am getting a perfectly good aortic, ejection fraction, which is definitely less than 20% there. And then I can do a feature tracking and look at his radial strain. When I get a radial strain, it is now, you can analyze this segmental strain when it picks, because you know it's a radial strain, so it is going to have thickening or positive strain. If I look at the septum, I know that it is peaking in the isovolumic contraction region, somewhere at around this 50 milliseconds. However, if I look at the strains in the posterolateral wall, they are having a late peaking somewhere at 300 and 350. So I know that there is a septolateral almost 300 millisecond delay, and which I definitely know that this is going to help by a CRT in this patient in addition to aortic wall replacement. Okay, so that is the first thing. I got a very clear dyssynchrony. Of course, on speckle tracking also I can get it, no doubt about it, provided you should have very good short axis images. Then this is the flow quantification of a aortic wall, in which the radiologist call it as phase contrast imaging, where every pixel in this particular image has got a velocity information. So throughout the cardiac cycle, it gives you the forward flow and also the reverse flow. Forward flow, as you know, that the data points are less, so your temporal resolution of flow quantification is much less than Doppler, because Doppler has got a resolution of even 5 milliseconds. So probably you may miss a peak velocity on the phase contrast imaging, but what is the power is the diastolic flow quantification. and the area under this curve gives me an exact quantification of AR and the regurgitation fraction, which I know is 26%. So that is some additional information I got. Then I can have very small, thin 3 to 4 millimeter sections cut across the aortic wall, perfectly planning the plane perpendicular to the tip of the leaflet. Now these images are not very great because the signal to noise ratio is going to be less because the slice thickness is very less. But I know that I am perfectly perpendicular. Why? Because I can see it in two longitudinal planes, one a 3-chamber view and one the coronal view, and I can plan the plane perfectly perpendicular and then take the images around this at 3 millimeter plane, so that I know the plane which at mid systole lies exactly at the tip. I can planimeter it. Now I know that this is calcium. I can do it on short axis echo image also, but with calcium sometimes you get such a bad reverberation artifacts that you really can't get a proper the aortic valve area. While here, since the calcium does not have any magnetic properties, it looks black, and actually it is giving you a perfectly good aortic valve area, and this aortic valve area is around 0.8 square centimeters, and I know that I am perfectly perpendicular by comparing in two orthogonal planes. Then this is what Dr. Sanjay mentioned about the T1 maps. Okay, don't get bogged down by the terminology. What it just, T1 is one of the magnetic characteristics of the tissue, and what you do is by pixel, what the software does is that according to the T1 values, it creates a parametric map and it plots it across this range of colors. So the lighter colors are higher T1 and the lower shades are lower T1 values. So here we see that the T1 values have significantly increased. So you take this T1 characteristics, which is a very objective data before giving contrast and then after giving contrast, okay, like this, after giving contrast. You subtract the two, you know the change in the blood volume. In the blood volume, you know the extracellular volume because you know the PCV. So in the blood, you know what is the extracellular volume, and you know the same ratio of change in T1 would be there in the myocardium. So you can get an extracellular volume by this method, and this is probably the only method by which you get an myocardial extracellular volume in an intact patient. So here we can see that extracellular volume has increased. Okay, each scanner will have its own T1 values and its own extracellular volumes data. You cannot compare two scanners even for the same company. So that is why they are shown in a parametric map, so that you get an idea that it is increased. What else I can do is that I can also look for a replacement fibrosis in this patient, and interestingly he doesn't have a replacement fibrosis except for a very small area at this insertion site, which is supposed to be very non-specific, and a very linear very linear streak in the septum, which obviously the septum has to have some disease because it has produced left bundle branch block. So from this I know there is a good dysynchrony between septum and lateral wall from feature tracking. I know that there is hardly any replacement fibrosis. This patient is going to have excellent prognosis after AVR and a CRT. So this information is very confidently I can give you over and above my resting echo image. And secondly, also I could get a very good planimetry and know that this is a bicuspid aortic wall and give a very good planimetry, which was technically difficult on the echo. And lastly, I can get the entire aorta and can, because as you know the bicuspid aortic wall is associated with aortopathy, so I can have a very good measurement of the aorta. And you can also see the jet, how it is hitting the anterior wall, and you know how difficult it would be to align the Doppler jets in these patients. But anyway, I get the information of the aorta. So there are 4-5 important pieces of information we could add to the echo information, which has got a direct significance in this patient's outcome. Okay, so this is how the things can help. Now let us take another case. Okay, now this is a 32-year-old male, and he is asymptomatic. He has dyspnea on exertion and palpitation. Now he has a hypertrophy, and there is no family history of sudden cardiac death. Now, as you know, this is the first thing you ask, because that is one of the and there is no history of unexplained syncope. As you know, these two things are very important in a patient of hypertrophy, where you are thinking of an hypertrophic cardiomyopathy. So these are the two important pieces from the history for risk stratification. This is the ECG, which is a very, very classical HCM, okay, very large voltage potentials, T inversions, and the echo shows you a asymmetric septal hypertrophy, and then you have to measure the thickness. As you know, any thickness above 30 millimeters is a high risk for sudden cardiac death. But how to measure it? That's a big, big problem, because as one study showed that actually the variability of measurements, inter-observer variability and restudy variability can be as high as 5 millimeters. That means someone who is crossing 25 millimeters on echo, you are already worried because you may be wrong by 5 millimeters. Secondly, so this is very important, and this need not have to be the septum, it can be focal anywhere in the myocardium. Okay. So it's best that on the echo from base to apex you go on scanning and take the thickest area. But many times the images may not be as great, especially on the anterolateral wall, because of some technical challenges, and one can measure a very significant hypertrophy there. However, this is the most third important risk factor, as we know. Then comes looking at for a EF and apical aneurysm, because these form the fourth and the fifth important risk factor for sudden cardiac death. Now, because of the apical cluttering, we can easily miss an apical small aneurysm, because the apical aneurysm may be of any size, but it can have the same risk of VTVF because it causes that subendocardial. So unless you are using an ultrasound enhancing agent, like in our lab we use very routinely, it's very, very likely that one can miss an apical aneurysm, which may look so good on the ultrasound imaging, but on a non-enhanced echo image, because of the apical cluttering, you can easily miss that, and which is a very important piece of sudden cardiac death risk stratification in our armamentarium. Dynamic LVOT obstruction, nothing like echo Doppler, because you can do Valsova, you can do exercise, you can do postprandial dimension, nothing can beat that. Then obviously Holter is the one where you have got a faster, longer and frequent VTs, that is the sixth risk factor. Then why do CMR? Many of these patients, if the echo window is poor, you can easily miss a thickness of this focal thickness of the myocardium, which an MRI can give you very well. Then if you have any suspicion of infiltrative disease, storage disease or athlete's heart, MRI can come in handy. When the ICD decision is very uncertain on these risk factors, if you want a precise LV thickness, precise EF and picking up the LV apical aneurysm, and then lower in the hierarchy is the late gadolinium enhancement and its progress. And if your center is doing a septal reduction surgery, having an MRI may be much easier, because the surgeon can understand the extent of hypertrophy and amount of resection that he wants to do. One can repeat it every 3 to 5 yearly. So this is how you can get a series of images from base to apex, so that you do not miss a focal hypertrophy. I think all of you have come across cases where you have got deep T inversions, you do echo in regular long axis, regular short axis, and you don't find any hypertrophy. But the hypertrophy may be just at the basal anterior wall, just at some apical inferior wall, which one can miss because of the technical difficulty and if you are not using ultrasound enhancing agents. Secondly, radially you can measure it very well, and you can avoid the trabecularseptum marginalis on the RV in the measurement, which many times on the echo becomes very difficult to know where is the RV trabecula. Secondly, apart from that, so the thing, and here the measurement, as I told you, the inter-observer variability is 5 millimeter. For the MRI, it comes down to 2 to 3 millimeters. So it is good point that clinical is that the moment you see a thickness of 25 millimeters or around that in the echo, be sure that you can still be 30 millimeters somewhere, because you have got a 5 millimeter variability. And in the MRI, if you are reaching at this region of 27, 28, again get alerted, because as you know, 30 millimeters and crossing that has a very high incidence of sudden cardiac death, and it need not have to be septum, it can be any focal territory. Second is looking at the LA volumes. Now LA volume, like the LG fibrosis, is a very low down in the hierarchy of risk factors, but a precise LA volume measurement is very easy with the biplane method on the MRI. And secondly, the precise EF calculation, because as you know that the EF falling 50% or lesser is a very strong predictor of CV death and sudden cardiac death, because arrhythmias in the patients with hypertrophic cardiomyopathy. So having a precise EF is so important. Secondly, even a very small aneurysms you can pick up. like this one. You can see a very small subtle aneurysm developed at the apex, and because of the mid cavity obstruction, and comes the late gadolinium enhancement. So these late gadolinium enhancements are very different than what we saw in the ischemic heart disease. In the ischemic heart disease, they were very sharply delineated, they were subendocardial or transmural, very glistening. The kind of late gadolinium enhancement here you get is because of the apoptosis of the cells. And as you know, the cells in the HCM, the myocardial cells in the HCM are in a disarray, and they keep on dying, and the fibrosis extends. So these are like lacy patterns in the septum, much more in the hypertrophied area, very common at the insertion sites of the septum, both on the either side, and they will be there in the hypertrophied areas. Not only that, you can have some certain crypts in the myocardium and certain lengthening of the leaflets. So there are so many features, and especially once you start seeing more and more these kind of patterns in the septum, you know that this is definitely a phenotype of a true sarcomeric hypertrophic cardiomyopathy. Then you can quantify it. Now, how do you quantify is that if you give an area of interest which you see the signal intensity is normal, then anything 5 standard deviation of above that or 6 standard deviation above that, the machine can easily identify, and then it can create the quantitative estimation. But this is very variable depending upon what kind of standard deviation you use, or you use the other method of the other methods of quantification. So it's variable. And so this particular number has come from a very tertiary institutes where they have a very selective bias of getting a high risk patients. So in real life, there may be in a population based studies, we still should know this particular number and a very standardization of measurement of the extent of LG. So that is why the this is the kind of LG quantification you can do. These are the T1 maps, and you can see that the very high T1 values you can see interspersed in the myocardium, and you can see that these are the areas where there is an extensive fibrosis, okay, as opposed to this lateral wall. This particular shade of yellow is a normal T1, while you can see all those red islands here is an extensive fibrosis. How it will help you? Actually, this will help the AI to actually create the LG maps without using gadolinium, okay, and this has already been done, the work is already been done. So probably in future you will know the extent of fibrosis, replacement fibrosis from the AI analysis without using gadolinium, because AI will read this image much better than us and can tell you where the fibrosis and can create the map of LGE here. So if you look at the hierarchy of risk stratification, we know that in the MRI can help you in the maximum wall thickness, focal, precise EF and apical aneurysm, and in the lower end it can tell you about the LGE, and in the lowest end it can give you a best LA dilatation. So that is how it can become complementary to the echo. Now let us change the gears here, and this is the 43-year-old male, progressive dyspnea to class 3, edema fit over this last 1 year. And this is his echo, and he has a good hypertrophy on the echo, and the moment a clinician sees this ECG, he says this can't be a hypertrophied heart if you are having an echo showing severe hypertrophy. So that means this is infiltration, because here you can see a pseudo infarction pattern. All the limb leads have hardly any voltage of 5 millimeters, and then suddenly you see the echo is so hypertrophied heart. So you know that this is not a healthy hypertrophy, and this is neither hypertrophic cardiomyopathy. So this has to be an infiltration. So we see the long axis, and you can see that there is hardly any apical to base motion. There is hardly any longitudinal motion. There is a very nice radial motion, but hardly any base to apex contraction. And the same thing is reflected. The Doppler shows a restrictive filling pattern, and all the longitudinal velocities S prime, E prime, A prime, they are all less than 5 millimeters, 5 centimeter per second. So that is very classical, as you know. And when you do a speckle tracking, you see something like this, which we call cherry on top, because it is only the apical deformation is well preserved, rest everything is gone. Because you know that this particular infiltration goes from subendocardium to epicardium and from base to apex. So the apex gets preserved last. These patients are emergency. First thing you do is do immediate serum protein immunofixation electrophoresis, serum and urine protein immunofixation electrophoresis. Try to look for monoclonal band, because that's an emergency. Those patients don't even survive AL amyloids. They don't even survive 6 months from diagnosis. So that's an emergency. So you look for, and once you have ruled out a monoclonal gammopathy, definitely you can go ahead with the MR, and this is the MR images, and you can see that if I go the longitudinal, there is hardly any longitudinal contraction, and then you can do a feature tracking and show that the GLS is significantly reduced, hardly any GLS, and then you look at the native T1 values, and you can see those native T1 values are in the 1500. No disease reaches there except the deposition of amyloid, okay, and especially the ATTR amyloid. And then you can look, as I told you, that you subtract this pre-T1 and post-gadolinium T1 values, and you know that that difference is only because of the gadolinium which is mopped up by the extracellular space. So that difference tells you the extracellular volume. Now normal extracellular volume would be around 20%. Here you can see it's going to 60-70%. This amount of expansion can occur only with the amyloid, and this slide you will see in all the MRI conferences, that if you have an extracellular volume extreme one and very high T1 values, there is no other disease but the amyloid. Secondly, this disease mops up the gadolinium into the myocardium so much that actually the cavity has a less gadolinium left, and that causes a very early nulling of the myocardium. I will not go into the technicalities, but just looking at this particular scout, you know that there is a lot of gadolinium in the myocardium and not. And the moment you look at their gadolinium enhancement, it is almost transmural, absolutely transmural, extensive gadolinium. You cannot have that kind of a gadolinium in any ischemic heart disease or in the HCM so far. And these are the patients when the urine and serum immunofixation electrophoresis is negative, then the pyrophosphate scan is 100% specific. Okay, so there you look at the pyrophosphate scan pick up by the heart versus the contralateral lung, it should be more than 1.5 times. So this is a classic case of ATTR cardiomyopathy. And why I am showing you this case, because this is the first case in India where we put him on tafamidis. And this tafamidis was actually given to him, we contacted Pfizer and he got it on compassionate ground before the tafamidis got introduced in India. Now 2 months, I think 1.5 months back, tafamidis got introduced in India. It is called as Vindamax. It is a 4,000 rupees a capsule per day, 61 milligram per day. So this patient got the benefit earlier because that time tafamidis is not there. So Pfizer provided it on compassionate ground. So anyway, so the thing is, when you see an hypertrophy like this, you don't know whether it is a amyloid, whether it is a hypertensive heart disease or the HCM. That there is one interesting thing is that there is a dissociation of EF and strain in amyloid. And so what happens is that if you take a ratio of EF to GLS, as you can see in this patient, it is 5. Generally you will see the EF is 60, GLS is 20, it is generally 3. Anything going above 4 or 4.5, think significantly that this can be amyloid, okay, because the EF doesn't go down that much, but the GLS drops significantly, and so that is why if it goes this range, it is generally an amyloid. Then there is another way to look at it, is that that among, now these are two cases of amyloid, okay. You don't know which one is ATTR and which one is AL. But remember, one thing is very interesting is that the ATTRs have got very significant hypertrophy, less clinical symptoms, while the AL patients have got less hypertrophy, but they are extremely bad, sick and heart failure patients. If you look at their mass to GLS ratio, okay, this case 1 and case 2, in the case 1, if you look at the mass, as I told you that we know that the MRI gives you an excellent myocardial mass, and also on feature tracking it gives you a good GLS. If you look in this patient, the mass to GLS ratio is 13. It's very high, very large mass and very low GLS, and that goes and this is a very classical ATTR. While the case 2 that we saw, which also was a hypertrophied, if you look at the mass and the GLS, the ratio is less than 10. So there is that someone who are getting that mass to GLS ratio more than 10, think of ATTR, and those with the lower ones think of AL, okay, and this really works in many patients. Let us change the gear. You can stop me anytime because there are hundreds of cases. You can stop me anytime. Now this is a case of a 65-year-old woman, acute chest pain and breathlessness. She received a COVID vaccination actually. She received a booster dose. And then the 2-3 days down the line, she had acute chest pain and breathlessness. And she was in she had a LV dysfunction, and there was a significant troponin elevation, okay, and if you look at her ECG here, there is a significant ST elevation from V2 to V6, and she had received the booster dose 3 days back. She has a LV dysfunction, troponin rise, and this is the echo. Now when you look at this echo, you are sure looking at this is apical ballooning syndrome and there is a dynamic LVOT obstruction, but obviously you can't say that with that ST elevation. It has to go through a STEMI protocol. So the thing is, this is her angio, RC is clean, left LED is clean, and the ECG on the recovery is baseline. So how does MRI can help me here? Now this is the MRI again showing you the apical ballooning as you could see that. And 1 minute, I'll just go ahead. Yeah, you can see the apical ballooning on the contraction. You can look at the short axis images again showing the apical dysfunction. But where the MRI tells me, if I look at the T2 maps, okay. Now what is T2 maps? As I told you, the T2 particular is another magnetic property which generally is look for edema. The moment there is a trapped water content in the myocardium, the T2 values will go very high. And when you put it on a map, you can change the colors of the map depending upon depending upon your aesthetic values. That you can see that the apex has got very high T2 values. You can look at the spectrum here, look at the myocardial values, and look at the apex, and a very sharp delineation like this. So you know that the apex is completely edematous, okay, completely edematous. You can even put the region of interest there and can see that the T2 values are in the range of 80, 84, and that is almost twice this. The normal values are around 40 milliseconds, okay. So the thing is, you can see that there is a complete edema which is very well demarcated, but and then the T1 values also go high because of the edema, and you can see that the entire thing is white there on this map. But you look at the lead gadolinium enhancement, there is no subendocardial enhancement here as you would expect in a hereditary infarct. What you have got is a slight rise in the signal because of the GAD retaining in the edematous tissue. So this is a very classical Takotsubo where you don't get a replacement fibrosis, you get a slight rise in the signal intensity because of the GAD in the expanded extracellular volume because of edema, and the T1 and T2 maps show you very significant edema, clear cut at the apex, okay. So there is so you know that this is not a epicardial coronary disease related dysfunction, this is a definite Takotsubo, okay. Let us look at a 16-year-old boy. He had probably a dengue 1 month back. Then he got recovered and immediately went to gym because you know the 60-year-olds are very particular about their body image. So while exercising, he had chest pain and then he became breathless. He was taken to one of my friend's hospital, and the moment he's a cardiologist, the moment he took him in the ICU, he had actually started having pulmonary edema. He had to put him on NIV. Then he had episodes of VT, so he had to shock him. After that, after conversion, he went into high-grade AV block that he had to put a temporary wire. So doing all that, he then shifted to us. So he had a narrow QRS ventricular tachycardia, and after that he had got this kind of a RBBB with CHB, then it converted to CHB into LBBB. So when you know that this kind of a person with a viral illness and then having a tachy and bradyrhythms, definitely you are dealing with a myocardial inflammation. Now this is the echo which shows a mild LV dilatation and some LV dysfunction, Now this is not a 16-year-old's LV, you know that this is definitely, there is a dysfunction. EF visually looks like 40% or so. So let us look at his MRI. Now this is his MRI which shows you that there is a, the same long axis, 1 minute. The same long axis images as you can see here as the echo, and then we have got this GLS which is just minus 13%, and this is your long axis views and the EF. Now obviously the MRI was done 4-5 days after removing the temporary wire, and this is 50% now. So now do the previous injury, the MRI has got some memory, and that is the difference of MRI as a imaging modality. It has got a tremendous memory of a tissue injury. So even if you do the MRI late, when the patient is stable, you still can see that there is so much of edema with large, this is a T2 map, and you can see that these are the normal T2 color, and you can see that here the pixels are showing you very high T2 values, and they are dispersed everywhere. You can see all these yellow bands here, some yellow bands here, some small yellow bands there, and you know that there is a diffuse edema. If I look at the T1 images, the same thing. This is a normal color for our T1 values of our scanner, and you can see that in the septum, you have got so many lighter colors interspersed all over the septum. This is a very classical diffuse edema. Okay, and if I look at even I can do the region of interest and look at the T1 values that has gone so high. I can give the gadolinium and again look at the T1 images, and you know that wherever the places the gadolinium goes and resides, the T1 values will suddenly drop, because gadolinium is a very paramagnetic substance, and you can see that now suddenly those areas which were light have become very dark because of a low T1 value. So that means the GAD has been taken up at multiple places where there is an inflammatory damage. And then even if I look at the extracellular volume, you can see that this patient has got these yellow areas where the extracellular volume has increased significantly. So this is typical area myocarditis. And when I look at the late gadolinium enhancement, you can see that there is so much of LG retention, which is not subendocardial, which is more epicardial, diffuse, focal, so and so forth, that you know that this can't be an ischemic area. What more than that, actually he also has got a clot in the right atrium. Why? Because he had a clot there because he had a temporary pacemaker put through the jugular, and that has caused the superior vena cava clot which was extending into the right atrium. And you can see the diffuse LG in the septum there. So if you look at the Lake-Louis criteria, the modified ones in 2018, the T1 and T2 map come quite high. So what you have to show as the main criteria, that there is a myocardial edema for which they recommend T2 maps, and you have to show non-ischemic myocardial injury by showing that the T1 have gone high, extracellular volume has gone high. So the maps for the first time have got some clinical recommendation. Up till now it is just a good to ogle at, just a beautification of the MRI images, but now they have got a use in the guidelines. And then supportive evidence, you have to either show a pericarditis or a systolic LV dysfunction, as we saw on our regular cine MRIs. Okay. The next thing I will just show you, one 43-year-old woman, and she is non-hypertensive. She had fever, cough and weight loss, shortness of breath, all signs of heart failure, admitted with orthopnea since 1 day. She had bilateral crepes, and she was obviously, everyone does COVID nowadays when they come with orthopnea, and this was her presentation, like a pulmonary edema, and obviously it was a COVID negative. And this is her ECG, and you can see that she has got multiple VPBs, sometimes bigeminy. And then you look at her echo. Now the moment the echocardiographer looks at this, he sees that there is a basal septal akinesia. Okay. And we know that if you have got a basal septal predilection, thinning and akinesia, we always think of sarcoid, correct? So we have a LV dilatation, we have got a basal septum which is scooped up, and then there is a akinesia. But there can be twist in the tail. Okay. Now here you can also see in short axis views that there is the inferior wall which is akinetic, there is some apical inferior which is akinetic. So that means this is a focal disease of non-coronary origin. Okay. And then we have got these long axis images again showing the same thing. So let us look at now beyond this, we cannot characterize the myocardium. Okay. But we know that there is a irritability, there are VPBs, there is a basal septal, non-coronary territory akinesia. So we have to think of some granuloma somewhere. And this is our MRI, which again shows you that there are certain basal areas where there is a akinesia and actually partial thinning too. And so also in the CMR short axis stack. and the EF is 33%, the EDV, ESVs are high. That tells you that this is a chronic disease process. This is a chronic disease process. Okay, this can't be, and then also you get an RV volume estimate. Now we will look at the LGE, and it is interesting to see that the BASEM has got a lot of focal LG, lot of areas of focal LG at the basal slices. If we look at the long axis, you can see that there are certain ones which are going transmurally, but definitely they are not like a coronary territory involvement. Then there are someone where there is a subendocardial subendocardium preservation, while a mid-myocardial enhancement. Here you can see that there are small blobs of LGE there, more predilection at the base. And so also in the long axis views, you can see some of those areas. You can see one here also, one here also. The T1s are quite high, extracellular volume is increased. Now this is a lady which is not acute myocarditis. You know from the volumes, with the volumes are like HbA1c of your disease. You know that the disease process is long, the volumes are large. You know the focal areas of akinesia tells you it's the focal disease, and now you see focal LGs, we tell you that is a focal granulomas most probably. So the commonest cause of these are obviously sarcoid, but don't forget tuberculosis also. Okay, so we have got these two ones which are very high on the list. Then comes the giant cell myocarditis, but these patients are very sick. They are generally in a fulminant myocarditis. Okay, so they are generally go in the shock. Then such kind of focal granulomas you can even get in an inflammatory bowel disease like Crohn's or ulcerative colitis, and lastly you can also get them in the SLEs too. Okay. So remember, these are the commonest ones. Obviously from this patient we know that there is nothing like Crohn's in her case, no SLE in her case. She is not in shock like a GCM. So the things remain between the sarcoid and tuberculosis. Other ones are very rare, we don't have to even worry about it. These are the patients where you want to see the disease activity and have a tissue diagnosis. So the best next modality is obviously the PET-CT. So in this PET-CT, I will stop it and we will go slowly, and you can see that the brain shows obviously good PET activity. As we enter the supraclavicular area, suddenly you see a large lymph node with a extensive activity. If I go down into the mediastinum, you can see a large activity in the precarinal lymph node here. And then if I go down, there are further ones here, okay, very close to the SVC, and again here infracarinal. And then if I go down, then there are so many mediastinal lymph nodes, okay, so many mediastinal lymph nodes. So this can be a sarcoid, definitely, very likely. In the myocardium, you have got a very focal one here. This doesn't show any enhancement. So all those LGs need not have to be active. Some of them may be just dead fibrotic granulomas too. But what has helped us here, we can avoid a myocardial biopsy because you had such a nice lymph node sitting there for you to catch up. Okay, you can easily get a biopsy from this, and you really don't have to go all the way around. Or if you had this, you can go by EBUS and get the biopsy there. So this is what we got the biopsy, and this is what the biopsy. This showed non-caseating granulomas, but you think this is sarcoid, but never relax. Always do their MANTU. And whatever biopsy material you get it, do TB PCR and also TB culture. Now this patient turned out to have a TB culture positive for MDR tuberculosis. So it could have been a catastrophic to just put on steroids. Okay, so that is lesson number one. Now the center which has got the largest experience is of obviously Dr. Narasimhan's group at CARE. What they do in this patient is they start the AKT and steroid together, and at end of 1 month when the LJ culture TB culture shows negative, then they withdraw the AKT and continue the steroids. Okay, I think that's a very good approach. And this patient, after 1 year, you can see that the activity in the lymph node is completely gone, and so also the myocardial activity completely gone. Even the lymph nodes in the stomach has completely vanished. Okay, so this you will always see these kind of, so always patients coming with focal regional wall motions, looks like a cardiomyopathy, has some ventricular tachy or bradyarrhythmias, especially the heart blocks, which cannot be explained by aging. Okay, think of sarcoid. Okay, and especially when you have got basal territory akinesias, but do not say blindly sarcoid, because tuberculosis can definitely overlay the picture, or it can be purely tuberculomas, may not be sarcoid at all. So just not getting non-caseating granuloma doesn't mean anything. Try to get the tissue biopsy, and the best way to get that is by locating a lymph node on PET-CT. Okay, shall I go ahead? There are 1 or 2 cases more. Can I go ahead for more than 2 cases? Okay, okay. So this is a 45-year-old male, class 3 dyspnea. He has a blood eosinophil count of 47%. Okay, his troponin is elevated, 2.6 nanogram per ml. He is ANA positive. And actually he has been referred to us by the neurologist because of small cerebral and cerebellar small infarcts. Okay, and this is his ECG. Okay, deep T inversions everywhere. Okay, deep T inversions, but no infarct. Okay, and if you look at the echo, you know. The moment you look at the echo, you know that the apex is not good. Apex is something fishy happening there. You take a closer look at the apex and you see a good infiltration there in the apex, but the underlying myocardium is contracting. Okay, so you have a good cavity infiltration, but the underlying myocardium is contracting. You look at the short axis and you see the same thing from base to apex, that this is the infiltration, but the myocardium, which is having a different grayscale, is contracting. Or if you give the ultrasound enhancing agent and keep the MI low, you can actually see the perfusion of myocardium here. You can see the perfusion of myocardium, and while this area has no perfusion there. Okay, no perfusion there. So you know that the underlying myocardium has got normal capillaries, they are contracting, and you have got a filling defect there with a hypereosinophilia. Okay, so you know that this is low flux. Okay, but so what more the MRI can show me? Okay, beyond this, there is something it can show which can be very, very interesting academically. Okay, and also will have some therapeutic potential. Okay, because I don't know this filling defect is active or is the fibrosis. It's like an advanced EMF. Okay, by now. So look at the MRI images, and the first thing you can see that the filling defect is actually quite hyper intense as compared to the myocardium. Okay, and you know it is distinct from the myocardium. If I look at the short axis, it shows me the same thing. But here is something which is interesting. If I look at the native T1 map, now the native T1 map, I just for the aesthetic pleasant thing, I will just change the color map and look at this. Now, if you look at the myocardium, it is red. Okay, so that is somewhere we expect the normal T1 values. Inside it, if I am thinking of a clot, it has to have a trapped plasma, that is water. Then the T1 value should go very high. So they should be something like in that white range. Instead, at the center of this filling defect, I get a very, very low T1 values. Okay, and that is so distinct to see this. This can happen unless there is some paramagnetic effect, and that is what is the heme. So that means this is the red clot where some of the RBCs are lysed and the heme is out, and that is bringing down the T1 values, and you can literally see the heme there now. Okay, so that is how we knew the tissue characterization of this. And if I look at I can even measure it by ROI and show that there are very low T1s there. Such kind of low T1s, myocardium, a lesser T1 is only in the fat, but below that is only iron. Okay, nothing else can be that. If I look at the T2 values, you can see the same thing. So this is the myocardial color, and you can see that this particular filling defect has got a lower colors, that is lower T2s. If it was just a trapped plasma because of a clot, or a white clot, as you have in acute MIs, which is a platelet rich white clot which has got a trapped plasma, T2 will be very high because it's the water. Here the T2 has come down significantly for the simple reason, this is not infarct related, this is an endothelial injury of hypereosinophilia because of the granules which liberate a very toxic substance for the endothelial injury, and the clot keeps on forming, and that has got a lot of red clot, and some of the central RBCs there, the heme has come out of the cell. And so this is a very active disease. That tells me that this is an active disease. If I look at the perfusion, very interestingly, there is no perfusion of that mass, but even before the contrast comes into it, you can see that it looks white, for the simple reason because these are also the kind of sequences where the things with a low T1 will be shown bright. So that means the clot which has got a heme inside, it looks white even before the contrast comes in. And when the contrast comes in, the GAD has got much stronger effect in reducing the T1, so that the clot becomes black, and you know that there is no revascularization of that. So this is not an old fibrotic EMF, this is a very active red clot. And if I look at the T1 values after giving the GAD, you can see that that between the clot and the myocardium is a very black area, because that's the area where the GAD has not gone in and the T1 has been brought down. So that means there is an injury there, because there is an endothelial injury there. So what I am having is, and again preserved T1 values here, because there is no GAD going inside. So I have a clot here with a heme inside. At the boundary I have got an endothelial injury, and then there is a normal myocardium, no infarct, normal myocardium. So the moment we look at the late gadolinium enhancement, you see the same thing. You have got this clot. Between the clot and myocardium, there is a LGE, which is called the fibrosis because of the endothelial injury, and a normal myocardium thing. So the second cause for a late gadolinium enhancement in the subendocardium after the infarct is the hypereosinophilic syndromes or the Loeffler syndrome. And then there is something by which you can actually bring out the characteristics of clot by imaging it at a long TI interval. We will not go into the basics of physics, but this is very interesting, because at this long interval of the inversion recovery, the interesting thing is that only clot remains black. Even the myocardium becomes gray. Okay, the clot remains black. So that is why MRI is very sensitive and very specific for clot diagnosis. And that brings me to the concept that the commonest mass in the heart is always clot, and the MRI can tell you that this is 100% clot by doing first the perfusion and then looking at a very long TI interval. I think I will stop here. Thank you.
Thank you, Dr. Burkule. As usual, your presentation was absolutely captivating, and needless to say, a great learning experience for all of us. And thankfully you stopped, otherwise it would have been a challenge on my part to ask you to stop. Can I invite my senior co-chair, Professor S.C. Mondol? Thank you for coming, although I understand he's an extremely busy person. He had got stuck. Yeah, and yes, please. We will open the session for discussion, Arupda. So your comments are most valued. Yes, please take the mic. And can I invite you to join us here as well?
Okay, I'll join there. Nothing can praise you, so I won't attempt for that. But one of your cases reminded me that in some cases we have to be thinking about mixed etiology. You have pointed out so many and stamped them ultimately the proper diagnosis, like the case of sarcoidosis, tuberculosis, etc. I had one case, florid case of rheumatoid arthritis, middle-aged lady, and she was being seen by a very eminent immunologist here, rheumatologist. And while seeing the patient, something prompted me out that it is not just a problem of rheumatoid cardiomyopathy. Something else was there. And I did a coronary angio, 3-vessel angio was positive. And I asked the surgeon to get it operated. She did well. Yeah. So we have to always look for the treatable cause. I think that should be the only message.
Yeah, I think it's a very valid point, because commonest things are common and they will be more common. So you will be right when you have got a more common diagnosis. So whenever you have an LV dysfunction like this and a focal this thing, in the same CMR study, if you do an adenosine stress perfusion, you have an ability to rule out an ischemia. And so also in the late gadolinium, if you have got subendocardial scars, you know that you are also dealing with an associated ischemic heart disease. So that is how the test becomes more wholesome. So you have these LG patterns of a myopathy also, but at the same time with a stress perfusion, combination of stress perfusion and LG, yeah, thank you. LG and stress perfusion, you can also rule out ischemia simultaneously. Okay, so that is a very valid point, that we have to think of the common thing first, not the rarer things first, and always rule out the ischemic heart disease in anything. Even in the chemotoxicity, first think of ischemic LV dysfunction, then go for this.
Yeah, before I open up the session for discussion, you very importantly brought out the point that extracellular volume estimation is only possible with CMR. And of course, you did not show us cases of DCM, both ischemic and non-ischemic, because they are very commonplace, I understand.
Yeah.
But how would you place extracellular volume estimation in the prognostication of DCM patients, ischemic versus vis-a-vis non-ischemic? And how do you see them, the changes in extracellular volume with reverse remodeling that is now happening with current day GDMT?
Yeah. This is a very important question that Dr. Soumitra Kumar has raised, which is a work in evolution. Now, what does the extracellular volume tells us, and what is different from LGE? Extracellular volume is the interstitial fibrosis, and now the interstitium has become our second target. All the time we are thinking of myocytes, but interstitium is another target that we are thinking about, and we already have a drug to affect the interstitium. We have the SGLT2 inhibitors. If you look at the SGLT2 inhibitor trials, their effect of reducing the heart failure, hospitalizations and the mortality is touted through reduction in the ECV, and that only the MRI sub-study showed. That there is a reduction in the extracellular volume, and that is how you probably have a remodeling of extracellular volume by the SGLT2 inhibitors, and that is why it is so useful in the heart failure with medium range or heart failure with preserved ejection fractions. So expansion of ECV is a very important indicator in HepF situation. That is one thing. Secondly, we won't use it for the ischemic or the focal disease, because anyway those damaged will be an increase in ECV. But this is very useful for a disease which is affecting the myocardium in toto, in entirety, like infiltration, like amyloid. A very large extracellular volume cannot happen anywhere. Second important thing, as you are asking about the prognosis, similar to LG has got a very strong prognosis. So LG, because of any cause, or LG anywhere, has got an increased CV events, both the heart failure hospitalization, heart failure mortality, and the sudden cardiac death. That is for sure, irrespective of etiology. But ECV is also competing with it, and especially further refining the reference for valve surgeries, especially in the stenotic lesions like aortic stenosis. There was the question earlier was asked. See, if we have an EF which is still preserved at 60%, severe aortic stenosis, patient asymptomatic, GLS on speckle tracking has now come down to 16, 15. Do you want to wait? Do you want to exercise? Or so and so forth. Now here the ECV had been shown to be useful as a third umpire. If there is an if there is a ECV expansion, then these patients are already developing significant interstitial fibrosis. Now these patients, even after AVR, may keep on coming with admissions with heart failure with preserved EF, because some of this may not even regress. Okay, and if there is a LG, that means there is a replacement fibrosis, then the fate is probably sealed, because even after the AVR, that is not going to regress. At least the ECV may regress to a certain extent. So that means we are just converting some AS into HepF for the future. And then sometimes you have a smaller prosthesis, so the gradients also remain so high. So though the guidelines will take a long time to take it into their fold, but ECV expansion and LG can be another further refinement for sending the patients for wall replacement, both for even the regurgitant lesions also has been shown by studies for AR and MR, okay, by the big groups like the Dr. Dipen Shah's group, and they have shown that even that there the ECV was very important, and it was additive to the regurgitation fraction and volume.
I think that...
Any questions?
Question from the audience or comment?
Yeah, please use the mic.
Good evening, sir. Sir, ECV volume expansion is also due to fibrosis, and replacement fibrosis is also. So, what is the basic difference if we go in like in the prognosis and histologically? What is the basic difference, and how can we expect the improvement in ECV volume after, like as you told?
Yeah. Correct. So the replacement fibrosis is what you see grossly as LG, which is irreversible in most of the places. If it is not a local edema or granuloma, most of the thing which is because of apoptosis or myocyte loss will be irreversible. Okay, and that is what you see by LG imaging. It's a very robust imaging. Okay, I don't see and very less variability in that. So there is a replacement which probably will never recover. Okay. Having said that, the LG, which is because of local edema, can definitely regress, because even you will always have a very large LGE on acute MI, which over the months will regress because of the edema loss and the fibrous tissue contracts. Then the LGE will be only in the fibrous tissue. ECV is much before that. It is only it is because of the interstitial fibrosis, okay, which is like the collagen laying down into the interstitium, okay. And now we know that the interstitium is also a very active tissue like the myocytes, okay, and it is causing the HEPs and stiff hearts and so on and so forth. So the ECV can still be reversible, because if these are amyloid deposits, then probably the treatment of AL with chemo, or even the treatment with tafamidis to prevent the further further amyloid deposits, the body can clear up the resting amyloid, the ECV can reduce. Nowadays we are not just looking at the ECV percentage, but we are calculating IECV. That means we are multiplying this percentage to the patient's myocardial mass per meter square, and that is much more reproducible and is much more powerful indicator of the long term. So normal is around less than 10 ml per gram per meter square. So anything about 10 ml per gram per meter square is generally this is called IECV, is expansion.
Any other questions or comment?
You have highlighted the importance of MR in HCM. Now, due to the inadequacy of availability of MR and also the problems of interpretation, how frequent do you recommend? ECHO is very much user-friendly, so how frequently do you recommend MR in case of HCM, non-HCM?
Yeah. This is an important practical question as a clinician, because not all HCMs need MRI, that is for sure. So the first thing is very obvious that we have the ECG looking like a HCM, but the echo we are really struggling to find hypertrophy, because there can be focal areas of hypertrophy which we may be missing. There the MRI will be in handy. Secondly, some of these elderly HCM patients, the echo windows may be very poor. There I think the MRI can help. Secondly, if you have an athlete with a possibility of an underlying HCM, there again the MRI come in handy by looking at the LG patterns, okay, whether it is a real phenotype of a sarcomeric HCM, or it is just because of overtraining that he has hypertrophy. Because in athletes there will be no ECV expansion, okay, and neither there will be this kind of a lacy pattern of fibrosis, except that the marathon runners, the master athletes, they do develop some LG at the insertion site because of the continuous training and some kind of RV pressure overload. They develop that kind of this thing, but that is late that from that. So there in athlete versus HCM it is very useful, because especially the Olympic grade athletes or the a very high athletic performance, the only way on echo that we know that this hypertrophy is pathological versus physiological, we have to detrain them, and most of the athletes will never like to get themselves detrained. So because you need 3 to 4 weeks of detraining to show a reversal of hypertrophy. So there I think the MRI comes in handy. Then lastly is that if you are following a patient of mid-LV cavity obstruction or even an apical HCM, most of the time we are taught as a resident that apical HCMs are very benign, but remember many of them go into either HEPF or some of them develop an apical aneurysm, and that can be a very significant prognostic factor for sudden cardiac death, because they get a subendocardial fibrosis which can generate VTVFs. So the thing is, if you are not using an ultrasound contrast regularly, then if you are following a patient of apical HCM or mid-cavity obstruction and he keeps on complaining of a anginal pain, okay, because that is because of subendocardial ischemia and microvascular dysfunction, I think get one MRI done to pick up that small apical aneurysm, which MRI can pick up because there is no restriction of planes and there is a normal cavity contrast without using any contrast. Just the sequence shows blood white and the myocardium black. So you can get an extraordinary contrast and pick up a small HCM. And lastly, you have the patient unexplained syncope, family history plus minus, he had some sudden cardiac death, but was it really related to HCM? So you are not sure on those points to think about an ICD, and you want some booster for your decision of ICD, then you can look at the lead guideline enhancement and quantification.
Thank you so much.
Okay, thank you. In fact, MR is a very good modalities for
if you please don't mind. I have got a young footballer who comes routinely for a checkup. Blood pressure is normal. He is asymptomatic. His ECG shows LVH. I do an echocardiography and find a concentric LVH, 15 to 16 millimeters. Now there is an issue. Do I suggest a CMR, or how do we advise him whether he should continue playing or restrict? Can you give me a suggestion?
I think this is everyone will have a deja vu, because this is a very classical situation that we all of us face as a cardiologist, because you will get these athletes and this kind of an hypertrophy. So here I don't say that MRI is going to give you 100% answer, but can point towards an athletic heart versus an HCM. So there are two things about it. One is that there's a very large study of athletic heart thickness from UK, because what they did was, when there was a London Olympics, they screened a lot of athletes, and they're all Olympic grade athletes. What they found that in white athletes, 14 millimeters and above is very unlikely, even Olympic grade athletes. And in Afro-Caribbeans, anything above 15 ml was very, very unlikely. I mean, rather, if you look at the scatter plot, at 15 ml, they had only 3 Afro-Caribbean athletes. So when you have something which is cross, and Indians generally have less hypertrophy as compared to the Afro-Caribbean ones. They generally have much more hypertrophy. So anything going above 14 millimeters, I will be very wary to call it as an athlete heart. Okay, that is one thing. And then here the MRI will help me in getting a precise thickness, because I will get a precise slice perpendicular to the long axis. In the echo, I may not be really many times confident, because slight tilting, I may be slightly oblong, and I may get a little higher thickness. So that is one thing that MRI will help me, just looking at the thickness part of it. And secondly, the T1 values. Generally, the athletes will have very minimal T1 rise, just because the myocytes are hypertrophied and they have got much more larger sarcomeres. But their T1 values will not go like HCM, going into that 1300 and that kind of one. So that is one thing. And generally, in the athletes, the myocyte expansion is at the expense of extracellular volume. Okay, that is one thing. So generally, their ECV will not expand. Unlike HCMs, the ECV will definitely increase, because the myocytes are not healthy. They are in a spiral fashion, and there is a lot of disarray. So they have got a lot of fibrosis. So their ECV will definitely go up. That is a third thing. Fourth is that generally, if this hypertrophy is related to the training, they generally have a very nice longitudinal function. So on the echo, their E primes, S primes, everything will be about 10. While HCM can never go to that level, however athletic the HCM guy may be. So generally their E prime, S primes, everything will be less than 7. GLS. The interesting thing is that the GLS at rest of these patients can be still low, even if they have got an athletic heart. So GLS, I won't ask you to do it, because it can fall in the athletes at rest. But you moment exercise them, their EF increases and GLS increases. HCM, it will never increase. Third thing is, most of these trainers, now luckily football is an aerobic activity, so they need to increase their stroke volume. So their LV dimensions are on the higher side. So any LV dimension going above 50 millimeters is very unlikely to be HCM, because HCM, the hypertrophy is always at the expense of LV cavity. So that is one thing. So they have a disproportionate large LA and a smaller LV, while the athletes have got both LA and LV dilated, because they want to increase the stroke volume. Unless he's a weightlifter, there the question is different. So footballer is like an intermittent burst of activity, highest level of physical fitness. There generally the LVs will be larger. So any LV dimension rise will tell me that this is not HCM, but this thing. So there are so many factors you can put it together. And again, look at the Holter also for arrhythmias and so on and so forth. And again, you can look at the peak VO2 on cardiopulmonary exercise test. HCM patient, however athletic he may be, he will be 80 to 90% for his age, gender matched peak VO2. While most of these footballers and those who are competitive sport, they will be 120% of the age, gender matched peak VO2. So these are so many different ways that we can put all the pieces together.
Actually, I have gone through an article, this group of patients, septal convexity. Septal convexity is very much important to differentiate the athletic heart from HCM. From the midline, if it is more than cut upon more than 7.5, then it indicates. These are the features of HCM.
Convexity towards
Yeah.
the cavity, yeah, correct.
Septal
So this is a very interesting observation, because obviously the hypertrophy is going to happen at the expense of cavity. So generally they will be convex towards the center of the cavity, while the hearts which are because of the training, they will expand, but they will, yeah, the diameters will increase, the thickness is increased, but they will not be convex towards the cavity. So there are so many other, a lot of pieces you will have to put together to say that this is athlete or versus non-athlete.
Short answer is, if I find in echo, the LB dimension is towards higher side, more than 50 millimeters. If there is no family history, and if there is no history of syncope in the past, I can leave him with echo only.
And
without
also the E primes, S primes, S primes,
Okay,
E
yeah.
primes, and GLS, all those things. Those are, and generally when you exercise them and peak exercise, look at their ejection fraction. Those are also very high from the baseline. So increase in 10% or so.
Yeah,
So this is
ejection
typical athlete.
So MR is not immediately necessary.
Yeah.
Thank you.